This video tutorial demonstrates the key principles I use when performing ultrasound-guided arterial line insertion, which I believe to be critical for succeeding, particularly when the anatomy is challenging. Assemble the required supplies and prepare for insertion in the usual manner. General principles apply, which I've described in more detail in my video on the anatomical landmark guided approach, which is linked to in the description to this video. Wherever possible, it's ideal to position yourself and the equipment so that you're inserting the cannula along your line of sight rather than across it. This avoids parallax error and generally increases accuracy for in-plane needle insertion in all ultrasound-guided procedures. Always use sterile saline or other fluid for skin probe contact, not ultrasound gel. Gel makes everything too slippery, which can affect delicate handling of the cannula and probe, and it also makes cleanup and dressing much more difficult. The increased friction between probe and skin when using saline is actually an advantage, as it lets you apply some gentle counter traction to stretch and fix loose skin and to fix the artery in position so it doesn't roll away from your needle tip. When draping the patient's hand to create a sterile feel, don't bunch up the drapes or otherwise impede your ability to flatten the cannula when advancing into the artery. The key to avoid puncturing the back wall of the artery is to have an appropriately flat needle trajectory, something we all know from intravenous cannulation. Note here how flat the cannula has to be, in many cases often lying right against the patient's skin, and observe what this corresponds to in terms of the needle tip and cannula position in the artery. If it was any steeper, the stylet tip would pierce the back wall with advancement. This is also why a long axis view of the artery and cannula is useful, as we will discuss later. Start by performing a scout scan of the radial artery, with three objectives in mind. First of which is to assess its diameter or caliber. The artery in the lower image is the normal size you would expect in an adult, while the upper image shows an unusually small artery, which should be suspected if the pulse is feeble and difficult to palpate despite a good non-invasive blood pressure measurement. The second objective is to locate a straight segment for cannulation and to exclude any tortuosities in the artery. The third objective is to ascertain the direction that the straight segment is traveling. Slide the probe up and down the wrist and note the direction of probe movement that keeps the artery stable on the screen. The artery should not slide to one side with probe movement. This allows us to choose our insertion point and to align our trajectory of insertion appropriately. In the transverse short axis view, an artery that bobs from side to side when sliding proximally and distally indicates that there is a tortuosity in the artery. This is more common and often more prominent in the elderly patient, as in this example. This can be further confirmed by turning the probe into a longitudinal orientation to try and get a long axis view and to ascertain if there is a straight segment. In this particular example, the kinks in the artery from the tortuosity are obvious. This is another example in which we've already committed to cannula skin insertion, but the long axis view shows that there is a tortuosity ahead of the arterial puncture point, and there's a high probability that the cannula will not thread smoothly. It's best in this case to start over at a new, more proximal insertion site, rather than take this risk. A fairly common anatomical anomaly is the presence of a superficial radial artery. This occurs in roughly 1 in 100 individuals and features in the radial artery that, instead of lying in the lateral groove next to the flexor tendons at the wrist, travels obliquely over the anatomical snuff box in the base of the thumb. This can be mistaken for a large cephalic vein when performing IV cannulation, and is one cause of inadvertent intraarterial injections of medications. The presence of a superficial radial artery should be suspected if the patient's radial arterial pulse is difficult to feel despite a normal, non-invasive blood pressure reading. There's usually an accessory radial artery that lies in the conventional expected location, but this is usually much smaller and thus leads to difficulty if radial arterial cannulation is attempted here. A superficial radial artery should also be suspected if the ultrasound scan shows an unusually small diameter radial artery at the wrist crease. Sliding the probe laterally and proximally will reveal another artery, usually larger, that's located more laterally near the anatomical snuff box, and that will slide medially and unite more proximally with the conventional radial artery in the distal third of the forearm. There are three strategies for arterial line insertion in this instance. First, we can trace the arteries proximally to where they unite into a single larger artery. Aim to pierce and cannulate the artery here. It may lie deeper at this more proximal location, but can be reached with a longer 20 gauge cannula, which I recommend always using anyway. Note, however, that as you reach the mid-forearm, the radial artery will start to dive deep to brachioradialis, where it may be less accessible. You should also watch out for the superficial radial nerve and lateral antebrachial cutaneous nerve, which lie relatively close by. Secondly, if it's feasible, examine the opposite radial artery with ultrasound, as the anomaly may be unilateral rather than bilateral. The third option is to perform ultrasound-guided cannulation of the ulnar artery, which I describe in more detail towards the end of this video. In older patients, another reason why the pulse may not be palpable at the wrist is that the artery may also be heavily calcified. In the most extreme examples, there can be a dropout shadow similar to that of bone, as seen here in the video that is looping on the left-hand side. There are often prominent venae comitantes which can be mistaken for the artery, although if you look closely, the swirling turbulence within the lumen rather than pulsatility shows that they are veins. In others, the calcium deposits are visible in the arterial wall and the lumen of the artery may be narrowed. Piercing a calcified artery requires more force and there's greater tendency for the artery to roll away, as illustrated in this video. Solutions include having very good technique to line up the cannula in the artery, and also having an assistant stretch the surrounding skin and soft tissues to fix the artery in place so it doesn't roll away. The other thing to do is to choose a different site or artery for cannulation. This brings us back to a key point for successful arterial cannulation. It's absolutely critical to choose a skin insertion point that is precisely in line with the center axis of the artery, and to advance in this line. If not, the cannula will tend to slide past the artery rather than piercing it. Trying to correct for inaccurate skin insertion by swinging or steering the cannula towards the artery as you advance risks piercing the artery at a tangent to its axis, which can then cause difficulty in threading the cannula after you've pierced it. This is particularly true for small or arteriosclerotic arteries. There are a few ways to help ensure accurate skin insertion. First, you can align the artery in the center of the screen using the M-mode marker or a dedicated centerline marker available on some machines. And then, line up your skin insertion point with the midline marker on the probe. There are, however, more precise methods to determine the optimal skin insertion site. If inserting an arterial line in awake patients, I recommend verifying the skin insertion point by using the local anesthetic infiltration needle as a finder. Insert it at a shallow angle into the subcutaneous tissues and slide the probe over it to visualize the needle tip. Tissue motion and local anesthetic spread as you anesthetize the skin insertion site will also show you where the needle tip is. If the tip isn't in line with the artery, adjust the skin insertion site accordingly, lateral or medial, until you are satisfied. If not using local anesthetic infiltration, you can also verify alignment by pressing the tip of the cannula into the skin without actually piercing it, sliding the probe towards you and over the cannula tip, and visualizing this indentation of skin before you actually make a puncture into the skin. If this indentation, and thus the cannula tip, isn't perfectly in line with the artery, adjust the skin insertion site appropriately in a lateral medial direction until you're satisfied. In some elderly patients, the overlying skin can be very loose and mobile. Gentle traction to fix the skin in place can be applied using the probe and the heel and fingers of the cannulating hand. This is where the friction of saline versus gel is an advantage. Insert the cannula at the chosen insertion point using a trajectory that is not too steep. A 30 to 45 degree angle can be used to pierce the skin more cleanly, but thereafter, this should be flattened to something closer to 20 or 30 degrees. The exact angle will depend on the depth of the artery. The shallower the depth, the flatter the trajectory should be, and vice versa. The principle is to have a trajectory that will avoid puncturing the back wall and allow the cannula to thread smoothly into the artery. Once the skin has been pierced, slide the probe towards the cannula tip to locate it. Unfortunately, the tip of the stylet is not always brightly echogenic within soft tissues, so use other cues of needle tip localization. An acoustic shadow is a sign that you are imaging the cannula shaft and not the tip. In this case, carefully slide the probe away from yourself until the shadow disappears to locate the tip. Bob the needle gently up and down and look for indentation of tissue layers to indicate that you are still centered on the target. Aim to advance smoothly and deliberately through each of the overlying tissue layers, feeling for the tactile sense of popping through each one to augment what you see on the ultrasound screen. Ideally, you want to see the arterial wall indent as the needle tip contacts it. Ensure the artery isn't sliding or rolling away as you apply more forward pressure, and look to feel a distinct pop or give as the arterial wall is pierced. Check for backflow of blood in the hub of the cannula, and with small scanning motions of the probe, you should also be able to see the bright echogenic dot of the metal stylet tip against the dark contrast of the arterial lumen. If you can visualize the stylet tip, you can advance it further under direct vision, keeping it in view by carefully sliding the probe away as you advance. Ensure you flatten the cannula trajectory appropriately to avoid piercing the back wall of the stylet tip. Advance just far enough to bring the plastic cannula itself into the artery. Some people like to walk almost the entire cannula into the artery under direct visualization in this manner. I don't recommend this. It simply isn't necessary and risks puncturing the back or side wall, particularly in narrow or tortuous arteries. Instead, advance the cannula just enough to be confident the cannula tip is in the lumen, which is a couple of millimeters at most, just like we do if performing surface landmark guided arterial line insertions. At that point, you can put the probe down and free up both your hands to handle the cannula. Check that the cannula is indeed within the vessel by withdrawing the stylet and observing for backflow of blood along the cannula. This is something I do for all vascular cannulation, intravenous or arterial, before I attempt to thread the cannula further into the vessel. This is the only 100% reliable sign that the cannula tip has reached and is still lying within the vessel lumen versus having punctured out the back wall. Always advance the cannula slowly and smoothly off the stationary stylet. in narrowed or tortuous arteries, I like to apply a slight rotatory motion as well. There should be absolutely no resistance to advancement. A very useful trick to avoid inadvertent puncture of the back wall, and especially when dealing with smaller diameter arteries, is to use a hybrid out-of-plane and in-plane technique. It begins by visualizing the vessel in a transverse short-axis view and advancing the needle out of plane to the beam, as described earlier. It's critical, as I've said, to line up the cannula as perfectly as possible with the center of the artery, particularly for this hybrid approach, using one or more of the methods that I described earlier. Once the artery is pierced, rotate the probe into a long axis view of the artery. Carefully slide the probe to align the beam with artery and cannula, which will now provide a long axis view of both the cannula and the arterial lumen. The main advantage is that the trajectory of the cannula can now be directly visualized and adjusted as it is advanced into the artery. In this example, we see that the stylet tip is resting against the back wall and will pierce it if we advance it any further. The trajectory is flattened to better align the cannula with the artery, and this minimizes the risk of piercing the back wall with a stylet tip. We can also visually confirm that a sufficient length of cannula has entered the artery, at which point the probe can be set aside and the cannula threaded in carefully using both hands, as I've already described. With an artery that has challenging characteristics, such as this one, which is narrow, deep, and relatively tortuous, I recommend using the short axis out of plane approach just to bring the cannula tip to contact the artery but without actually piercing it. Then rotate the probe into a long axis in plane view and align both the arterial lumen and the cannula before committing to arterial puncture. In this way, entry into the artery can be directly visualized and the tip then guided accurately into the lumen with small controlled adjustments to the trajectory. This minimizes the risk of piercing the side or back walls. As I've said, entry of the cannula tip, not just the stylet, can also be confirmed by direct vision. At this point, put the probe aside and focus on threading the cannula carefully and smoothly, using both hands for control. If the radial artery is not accessible for any reason, because it's diseased or of abnormally small caliber, the ulnar artery can be cannulated as an alternative. This should never be done by palpation alone, as the ulnar nerve is immediately adjacent to the medial aspect of the ulnar artery and is at risk of damage. Ultrasound-guided ulnar artery cannulation, though, is safe as long as you have good ultrasound-guided technique and you are precise and accurate with your needle artery alignment. This video illustrates ulnar artery cannulation in a patient with an unusually small radial artery, although not because there is a presence of a superficial radial artery. The ulnar artery, on the other hand, is of normal caliber, and the ulnar nerve is visible medial to it. Releasing probe pressure reveals the usual accompanying veins, the venae comitantes, one of which happens to be lying superficial to the artery. I do not, however, consider this to be a significant obstacle. What's most critical is to establish a skin insertion site that's precisely in line with the artery and well away from the nerve. Here I'm using a 25 gauge local anesthetic infiltration needle to find this spot. My initial insertion site is too medial, lying over the nerve. A more lateral site is chosen and confirmed by hydrolocation and tissue motion using the same local anesthetic infiltration needle. Once I've verified this correct insertion site, the cannula is inserted. But note here that there is still a tendency of the artery to roll away from the needle tip as it is advanced, which risks damage to the nerve. It's thus critical to be very controlled and deliberate with your movements to center the needle on the artery before attempting to pierce it. Watch for the artery to indent or compress rather than roll before pushing forward to pierce the wall. Feel for a pop, and then slide the probe slightly proximally away from you to visualize the stylet tip within the arterial lumen. Confirm backflow of blood into the hub. Advance a couple of millimeters, far enough to bring the cannula tip into the artery, and then as described, set the probe aside to complete cannula advancement using both hands. One last note of caution before performing ulnar artery cannulation. Consider if the collateral circulation from the radial artery will be sufficient to avoid ischemia of the hand. If the ipsilateral radial artery has already been traumatized with multiple failed attempts, it's advisable to target the other arm or to use a different site entirely. I'll end with a final example that illustrates the importance of developing and practicing good technique. Patients with significant arteriosclerosis and calcification often present the most challenging arterial cannulation. As I mentioned earlier, in these patients, radial pulses are often impalpable, and on ultrasound, the artery can mimic the appearance of bone with a dropout shadow from the calcified wall. The vessel lumen is often narrowed and small, which can lead to difficulties with threading the cannula or even a guide wire if precision is not achieved. As I've repeatedly emphasized, it's critical to start the insertion precisely in line with the central axis of the artery. If not, the artery will tend to slide away as attempts are made to pierce the hardened wall, which is what you see happening here. Even if you do manage to steer into and pierce the artery as my trainee has done here, shown on a long axis view, there's a high probability that you'll have difficulty threading the cannula or even a guide wire. And this was what happened here, despite brisk arterial backflow, because the entry was oblique to the long axis of the artery and the guide wire was abutting the rigid side wall of the artery rather than advancing along the lumen. For the subsequent attempt, I engaged in a more detailed scout scan, including a long axis view to identify a straight segment and to assess the patency and size of the arterial lumen. I then used my local anesthetic infiltration needle to identify a skin insertion site that is precisely in line with the artery. The tip of this needle can be seen here. The cannula itself is then advanced with careful tracking of the tip. In a calcified artery, more force is needed to pierce the wall, but this still needs to be done with control and with the tip precisely centered on the artery. There's often a tactile crunch as the arterial wall is pierced. The long axis view can be attempted for more accuracy. However, in this case, the calcification makes it very difficult to distinguish the actual tip of the stylet. With gentle rocking motions, though, I can still appreciate that the tip is likely within the lumen and has not pierced the back wall, and that the trajectory is appropriately shallow to thread the cannula forward. There is arterial backflow into the cannula hub, so I therefore put the probe aside and focus on completing the cannulation smoothly using all the principles that I've described in this video, as well as in my other video on landmark guided arterial cannulation.